So, video recording already. I'm going to share my screen. Yesterday, we actually started with yesterday we discussed microgranular adenosis. I just want to quickly run over it for the sake of the recording we have. Microgranular adenosis.
Let the screen be big.
Yes, it is. Can you see?
But okay, maybe let me also now look at my own because
Let me make it bigger.
have I exceeded somewhere? Oh,
Look at mine.
okay. Yeah, it's bigger actually, but maybe there's a way I can also make it big in my own self.
Yes, just do you have a mouse? Do you have a mouse?
I can use the yes.
You have a mouse.
I've used what's called now. Uh, full screen. Yes,
You
I
have,
do.
yes, then press Control on your keyboard. And at the same time, use your mouse to scroll up and down to reduce or increase the size of the font.
Okay, I've been able to do it, but then I want to remove. Okay, yes, I've done it.
Very good. So just use press Control and then be using your mouse to scroll up or down. That will reduce or decrease depending on what you want. So within microgranular adenosis says today, we say this resembles well differentiated adenocarcinoma of the breast, but the difference is that it has only one layer, no epithelial layer, and it has eosinophilic secretions resembling colloidal secretions. Then for female histochemistry, you differentiate it from other cancers because it is negative for ER, PR, and also negative for my epithelial markers like P63, slip nodule chain, heavy myosin chain. Then also it is positive for S100. But normal tumors, especially luminal E tumors of the breast cancer, will be ER, PR positive, there will be S100 negative. Then there was also like epithelial markers, of course. So now we stop somewhere on that. So let's go to the next question now. So here we have a case of this is a lymph node. A 49-year-old woman presents with a palpable left centimeter breast mass and condyle biopsy shows invasive ductal carcinoma. What
Okay.
C staging is this? What C staging is this?
Let me just look at it.
4 cm left breast cancer.
Oh, wait, don't. Hello, you change it.
No, I just went to CAP protocols.
Wait. Let's look. Let's find it. Let me do it before you look at. Let me try to
Yes.
answer it before we go to
No
cap
problem.
protocol.
Just I'll be answering it. I'm already opening, but don't worry, be answering it. So what is it? What do you think it
I
is?
can't see the question again.
No, not the question. I'm saying what T staging is this cancer? 4 cm breast cancer.
Okay, T2. T2.
T2.
Yeah.
Okay, very good. It's T2.
Let me look at the
Very
question.
good. So she is treated with neoadjuvant chemotherapy. Subsequent lumpectomy shows no residual carcinoma in the breast. Sentinel lymph node biopsy is performed. No signs of symptoms of metastasis exist. However, circulating tumor cells are identified in the blood. Which of the following statements about data elements from the checklist for the supporting invasive carcinoma is most accurate for this patient? So this patient was, this is the two question.
I can't remember.
Okay, so let's quickly let's look at the CAP protocol.
Yeah, I said D. Okay.
CAP protocol. Looking forward to invite this also begin. Uh, So PN0IT is ITC link. ITC stands for what? Isolated tumor cells only, malignant clusters no larger than 0.2 millimeters in regional lymph nodes. That's I plus isolated tumor cells. So in lymph nodes, whereas this one is
In the blood.
so it's in the blood. Let's look at this again. This patient had lymph nodes with tumor cells. What we find? Circulating tumor cells identified in the blood. Maybe this less than 0.2 millimeters for isolated tumor cells. Here, N0 is actually give me that bag. N0 molecular plus. This what you saw is in regional lymph nodes. Actually, it's in blood, not in regional lymph nodes. But this one is in regional lymph nodes. Molecular means when you do reverse transcription reaction, you can pick it up, but no isolated tumor cells detected. Anyway, let's try it out at once. So I don't waste so much time. But
I said D.
so today is Monday.
What's the answer? Answer it.
No, what to answer it right now. So, on the 28th. Where is the image? There's supposed to be an image here. I don't know what this image is about. This is a lymph node, right? 28. It looks to me like a lymph node. But let's see this lymph node. Does this lymph node have metastasis? April 8. This is a lymph node. Looks like this is a capsule. There's some fat here, some lymphoid tissue. There's scarring. It feels scarring. And then let me see. This looks like glandular tissue. This is glandular tissue. Glandular tissue. We shouldn't see glandular tissue at all in 2020 in lymph nodes. And if you see glandular tissue in lymph nodes and it's less than 0.2 millimeters, then that's micrometastasis. So maybe this answer may be E. Well, you're right. I don't know ChatGPT said D. Fibrous scarring in lymph node without carcinoma suggests prior involvement by carcinoma. So what is true in this patient is just that this, okay.
Where is the answer?
Fibrous, I don't know your answer
Okay,
yet,
you have
but
copied the explanation there, right?
I copied the answer. The answer is not yet out. I just wanted ChatGPT to try to provide an answer to. So ChatGPT said that there's fibrous scarring here, but I don't know if the let's see. Let's see what the answer is. Is the answer. D is the answer. So he said fibrous scarring in a lymph node. In the setting of this actually has fibrous scarring. There's no tumor here. Wow. Lymph node after neoadjuvant chemotherapy. Microscopic image of the lymph node after neoadjuvant chemotherapy shows fibrous scarring and no residual cancer. So these are in fact, there's nothing in the lymph node that is tumor. So it's not very clear. So unless something in the lymph node is very clearly tumor, we shouldn't call it tumor. I was already calling this probably glandular formation of tumor. So that's why I missed it. So there's actually fibrous scarring. You know that when we report treatment response in CAP protocol, we call it complete pathologic response. If you find a residual cancer, we call it complete pathologic response. You put Y in front. Y stands for post-neoadjuvant chemotherapy, and no residual cancer means complete pathologic response. Patients with pathologic Pathological complete response. Absence of residual invasive carcinoma in both the breast and lymph node should be categorized as YPT 0 and 0. So this case, they found it in the blood. The question is, that means the one we found in the blood is not significant.
Mm-hmm.
Let's see. This patient was, did we see anything in the blood? Secretory tumor cells identified. Okay, so this was where the confusion came, the blood. But if the biopsy is fibrotic, that's why PT0 and 0. Let's look at what ChatGPT said. Fibroids carrying in the lymph node in the setting of neoadjuvant chemotherapy often indicates a prior site of metastasis when the tumor cells have been eradicated by treatment, leaving only fibrotic tissue behind. Lymph nodes with tumor clusters less than 0.2 millimeters are considered to contain isolated tumor cells, PL0IT, and not true metastasis. So you cannot call them TN1. Oh, lymph node with tumor cell clusters less than 0.2 millimeters are considered to contain isolated
Isolated
tumor
tumors.
cells and are not true metastasis. They are not reliable they're not reliably indicative of residual nodal disease after complete treatment response. So if the tumor cells are less than 1.2 millimeters, isolated tumor cells, we don't count them as true metastasis.
Yes.
So, so, so the lymph, and not to talk of even not to talk of if they're in the blood. So that's why this will be YPN0, YPT0 and 0. So lymph nodes with cells less than 0 point are contained. Pathological staging. If no residual carcinoma is found in the breast and only isolated tumor cells are found in the lymph nodes, the staging is PT0, PN0, I plus, CM0. Here they call it IT. So the N1 means true metastasis greater than 0.2 millimeters. That's what N1 means. PTN1. Let's go to N1. N0 means no regional lymph node metastasis identified. N0 I plus means isolated tumor cells, not greater than 0.2. Then PN1, it's metastasis. Anything PN1 means greater than 0.2 millimeters. Okay. So in this case, we cannot call it PN1 because it's less than 0.2 millimeters. So this is wrong. So the number of lymph nodes with isolated tumor cells is not reliable for determining pre-treatment nodal status because chemotherapy can eliminate larger metastases, leaving behind only tiny foci or scans. So let's quickly go to this point. So what's the main thing we gain from this question?
Well, as regards that when you do not have tumor cells in the lymph node, but you have fibrosis and then tumor cells in the blood, that lymph node, you interpret it as the fibrous carrier as that, oh, the lymph node had a previous what's it called, involvement.
There's neoadjuvant chemotherapy. Yeah, with previous
Ye-
involvement. Yes, you're right.
Yes, before the treatment. And then the grading, that metastasis in the blood, it doesn't affect the PTN staging,
Yeah.
but you can put it as CMO IT, isolated tumor cells in the blood. So it's gonna like be YPTONO, then because there's M is still MO, but you put circulating CMOIT.
Okay, let's look at that. Let's look at that. CMOIT. Let's see.
So the staging in this one is PTO, NO, then CMOIT. Isolated tumor cells in the blood.
Mm. I didn't see any place where they put that here. See, but let's
Is
go
in
see
is
what
in
this is.
is in the test they wrote. Is in one of those options.
Yeah.
Yeah, that's this one.
Mhm.
Can you see it?
Yeah.
YP.
What is this? What is this? Hmm? Bad. Yeah, CM0IT is correct because it's the evidence of distant sex metastasis. But more certainly was CMOIT. Do you know that this CMOIT is not even the CAP protocol? CMOIT. Let me see. Is M. Let's go to M. This is M. M is CMO circulating. This is pathology CMOIT. Okay. That is C circulating PM0. Instead of PM0 to be CMOIT. Okay, very good. So let's quickly look at some questions and then we'll be done with this particular question. We're almost done with this question now. Yeah, we're having some delay here. Okay, let's go to the next
You
question
can
where
you
we'll
can
see
aim
what we
to
get.
get to at least 20 or 25 today. You know, we are
Okay.
just in number 6.
Yes, that'll be like half of it. But let's see how much we can go and without compromising quality. All of the following statements regarding recurrent breast cancer are true, except let's look at it and let me know your answer and I'll say my answer. Let's read through it.
Well, I would take C.
You take E. Okay. I don't know why this is still giving me trouble. I think it's working. It's trying to work it out. Okay, let's test this. Hmm. We'll come back to it. Let's see this. Look at the questions now. In patients who have undergone adjuvant chemotherapy, which histologic finding in the lymph node suggests prior carcinoma involvement?
Fibrous scanning.
Yes, fibrous scarring. Yes, fibrous scarring. Yes. Question number 2. What prefix is added to the TNM descriptor when staging is assessed after neoadjuvant chemotherapy?
Why?
Why? Which statement is true regarding isolated tumor cells in lymph nodes after neoadjuvant chemotherapy? A, they signified complete pathological response. B, they indicate partial response to therapy. C, they
C.
are irrelevant to staging.
Hmm.
D, they upgrade nodal staging to N2.
Okay. Incomplete response.
You get partial response because the isolated tumor cell. That's why we put it in I, right?
Okay.
I plus. So they indicate partial response to therapy. Any tumor cells, including isolated ones, signify incomplete
In the
response.
lymph node, okay. Partial
In
response.
the lymph node, In this patient, there was nothing in the lymph node, but it was circulating. That's why it was CMO I plus. You're right. CMO. The correct name was YPT0,
D,
PN0, CMIT.
okay.
Yes, isolated tumor cells. 4. What is the correct
D,
pathologic staging for a patient with no residual tumor after neoadjuvant chemotherapy but circulating tumor cells?
B, YPTO, PNO, CMOIT. P,
If not O, it's 0.
0.
YPT0, PN0, CM0IT.
Okay.
No residual tumor and circulating tumor cells. Post-treatment is staged YPT0, PN0, CM0IT. Question number 5. Following your adjuvant chemotherapy, what does the detection of fibrosis without tumor in lymph nodes suggest?
Prior
Okay.
involvement. D,
Yeah. So prior tumor involvement, fibrosis represents repression after metastatic tumor eradication. Number 6. In which group is reporting of lymph node fibrosis recommended? A. Patient receiving primary excision without chemotherapy. B. Patient receiving neoadjuvant chemotherapy. C. Patient with chemo DCIS. Patient with like chemotherapy. Which one?
B, receiving the adjuvant chemotherapy.
Yes. So that one, fibrosis reporting applies to different therapy settings. You don't report fibrosis in normal patients who have not undergone neoadjuvant chemotherapy. What's neoadjuvant chemotherapy?
Neoadjuvant is that should be after the surgery.
No, that's before surgery.
Okay.
Let's look at it quickly.
What's after the surgery?
Adjuvant chemotherapy. The goal of neoadjuvant chemotherapy is to shrink the tumor to make the surgery more manageable.
Okay, okay.
Types of chemotherapy. Because that's why I actually needs neoadjuvant, not adjuvant chemotherapy. Because they are shrink it before surgery. After surgery, we now remove the breasts. The breasts are so big and huge that we can't operate them without leaving residual. So we do surgery for them. After surgery, we now remove the breast and send to us. We have a lot of such breast in our center. It's the best breast to preview because you will not see any cancer. You'll be everything you'll be taking no cancer, no cancer. I mean, very easy to use synoptic reports. Synoptic reports are a pain. But when you have such breasts that have complete response, it makes life easier for you. So this is that when you get such breasts, the cancer would have disappeared. A lot of time there's cure. The cancer will not be found again. It's just areas of fibrosis in the breast. That's the area where the cancer was before, residual fibrosis. So that's the essence. Same thing with colon cancer. We shrink the colon cancer sometimes, even disappears. When you now do surgery, you see nothing remaining. So the essence of neoadjuvant is that this cancer is too big, we'll shrink it. Then we do go and remove it. And then they have get higher success rate. So the adjuvant chemotherapy is chemotherapy given before the main treatment, usually surgery or radiation, sometimes given before radiation. It shrinks tumor to make it easy to remove surgically, increases the chance of successful surgery with less extensive procedures, assess how well the tumor responds to chemotherapy. That's the essence of the pathologist. Now I want to know, is there complete pathology? That's PTZ, why PT0 is complete pathologic response or pathologic complete response. That's what they call it. Breast cancer patient may receive neoadjuvant chemotherapy to shrink tumors and allow for breast conserving surgery instead of a mastectomy. Sometimes it makes you overcome mastectomy. Adjuvant chemotherapy is given after the main treatment, usually after surgery, to destroy any microscopic cancer cells that remain. So if you have microscopic cancer cells after this surgery now, like the circulating tumor cells in the lymph nodes, we'll now go ahead and give another chemotherapy. That chemotherapy will now be known as what?
Adjuvant.
Adjuvant chemotherapy. It reduces the risk, or sometimes some people will not even give you adjuvant. They will just remove the tumor. And if there's metastasis after the surgery, they see the lymph node metastasis, they now go ahead to give chemotherapy. So they do mastectomy with lymph node dissection, and they now find out that there was some metastasis. They go ahead and do radiation. That's adjuvant. It reduces the risk of cancer recurrence. After removal of colon cancer, patients may receive adjuvant chemotherapy to lower the risk of cancer returning. So sometimes cancer is not just to do with surgery. It's to do with surgery and with chemotherapy. First line chemotherapy is also another technology. The initial or main treatment when surgery isn't an option. So when there's no surgery at all involved, we don't use the word adjuvant or neoadjuvant. Neoadjuvant to adjuvant always is only in relation to surgery or radiation, as a secondary intervention or something. I mean, primary, is in relation to either surgery or radiation. But when you're not going to do surgery at all, or you're not going to do maybe radiation or something, you call it primary or first line chemotherapy. Cancer has already spread, so to use to control cancer, relieve symptoms, prolong life. That's primary chemotherapy. Then palliative chemotherapy is not for cure. Those will relieve symptoms and quality of life. Concurrent chemotherapy is being given together with that's what we call chemoradiation. Induction chemotherapy is used more in heme parts like leukemia. The first cycle to induce a remission. After that, you now do consolidation therapy, and then maintenance therapy. That's for leukemia. So we'll come to that later. Okay, let's come back to question. If fibrosis is seen,
Oh.
if fibrosis is seen, what will be?
NO.
N0.
Without residual carcinoma.
Yes. N0. Even if fibrosis suggests prior metastasis, you see N0. Okay. Is the number of lymph nodes with isolated tumor cells after chemotherapy reliable for pre-treatment nodal status assessment? What is this? Is this question clear? What is this?
I'm not very sure.
Number 2. Let's clarify this question. The question looks somehow not too clear to me too. Okay. Is the number of lymph nodes with isolated tumor cells after chemotherapy reliable for assessing treatment nodal status? Isolated tumor cells are tumor cells that are less than 0.2 millimeters found in lymph nodes. They are too small to cause a palpable lymph node enlargement. They may be detected only by sensitive method like IHC or molecular assays. You know that sometimes lymph nodes will just look blue under the microscope. But so what kind of IHC will they use to detect if there's a tumor in the lymph node?
To detect tumor in the lymph node?
Yeah, like breast cancer.
Maybe you can use CK5, CK6.
Use epithelial markers. What are the most popular epithelial markers you know?
I started one. I said CK5, CK6.
They're not very popular. They're not very comprehensive. They're not like, they will need those that are like jack of all trades, very, very, very sensitive. I'll put it down.
Like AE1, AE3, right?
AE1, AE13, AE13. Perfect.
That's pancytokeratin.
Perfect. Pancytokeratin. So AE1, AE3, A13. Let's see if we can. They want it. I don't know why this one's is not done. I don't want this. But there's so many of them. CK20. This is a broad spectrum keratin. Well, let's say what IHCs can detect epithelial cancers in lymph nodes. So sometimes this tumor cells are going to be hiding. Remember that these are epithelial cells, epithelial cancers, and lymph nodes are lymphoid series, so they won't stay. But this IHCs will pick them up. Okay, so parastatic keratin, very good. A1, A3, CAM 5.2, very good. CAM 5.2. This targets low molecular. This one has wide range. EMA, CK7, CK20, but these are more specific for different things. Those ones, look at those ones later. No, what important is A1A, this CAM 5.2, EMA. These are the important things. We said for NGA, microglandular adenosis, that I think EMA can be positive. Which one is? What did we see? Is it EMA? Which one? What did we mention EMA yesterday? Is it in microglandular adenosis?
Your camera is S100 positive,
Positive. Yeah.
but I think the epithelial marker is negative, EMA negative.
EMA negative. Okay, I think I'll look at it later or something. I remember. EMA. Okay. How does EMA stain microglandular adenosis? Okay, let's come back here quickly. So the impact of what is this? EMA is fairly positive in epithelial cells. So it's going to be stain, it's going to be EMA positive, but this 100 negative. Now let's come to impact of chemotherapy on lymph nodes. So neoadjuvant chemotherapy before surgery can drastically alter the appearance and content of lymph nodes. They give what we call complete pathological response. That's the diagnosis normally render. Cancer cells can be entirely eradicated from the lymph nodes. Partial response means cancer burden can be greatly reduced from bulky disease to only isolated tumor cells or micrometastasis. How do you define isolated tumor cells or micrometastasis? What's the definition?
Isolated tumor cells.
How do you define it? Less than 0.2 millimeter. Remember? Is it 2 millimeters? Let me see. Less than. Again, 0.2 millimeter. Now, why post-therapy isolated tumor cells cannot accurately reflect pre-therapy nodal status? What is this? Chemotherapy can completely clear a lymph node that was previously heavily involved by tumor. Residual minimal disease. Sometimes only tiny clusters, isolated tumor cells are left after large deposits are eliminated. Tumor regression. What remains of micrometastasis does not represent the original tumor body. Pretreatment heterogeneity. Different nodes might have had varying levels of tumor body before therapy. Post-therapy findings cannot reliably reverse engineer this information. Let's read that. The post-treatment is for prognosis, but not reliable for original pathologic staging. So even minimal ITC after chemotherapy can have different prognostic implications compared to untreated disease. So can chemotherapy eradicate cancer in lymph node? Yes, sometimes completely. Can ITCs post-therapy tell you how big or how involved the lymph nodes were before? No. Is post-treatment ITC count a reliable measure of pretreatment body? No, because therapy modifies the nodal disease significantly. Should pre-treatment imaging biopsy guide initial nodal status? Yes, always. So So the essence of what I'm taking out of here is that after chemo, the ITCs are taken out after surgery, so chemotherapy cannot reliably tell you the degree of involvement of that lymph node before surgery. You know that
Yes.
when we look at lymph nodes assessments in cancer, in resection, what are the things you look at for lymph nodes? At least for lymph nodes, if you're looking at in for involvement, what do you look out for? If you're looking at a lymph node under a microscope, what are the parameters you're looking for in a cancer, in positive cancer in the lymph node? What will we be looking at for?
Architectural distortion.
Yes, what is that thing? There are some important things that I want to look at for.
The number of lymph nodes involved.
Yes, number of lymph nodes involved. Yes. What other things? Then this lymph node involvement, is it micrometastasis or macrometastasis? Then exact number. Then the other thing I'm looking out for as the size, this nodal size, the size of the largest deposits. In the axillary lymph node, what's the size of the level, like head and neck tumor now? Level 1A, meaning 3 lymph nodes are positive. What's the largest nodal deposit? What's the size? They measure it. This is very important. ENE, extranodal extension. Is the cancer going beyond the lymph node? I'll give an example of the extranodal extension. Let's look at visual picture. Extranodal. So let's come here. Let's see. Extranodal extension lymph node pictures. So they check that we look at the. So if you're reporting a lymph node, say in this level 1A of this 3 lymph nodes out of 10 lymph nodes positive for cancer, largest deposit is 10 millimeters, extranodal extension present. Look at it. This is supposed to be a capsule. This is supposed to be a capsule, but you see tumor extending to this place. This is tumor extending beyond the capsule. Extranodal extension. Let me see. I will get a very perfect picture. Very good. You see, this is lymph node. This is the capsule. After the capsule has finished, you see tumor here. In this, outside this capsule, that's extranodal extension. This is capsule. This tumor growing here beyond the capsule. This extranodal extension. So you always want to look out for features of extranodal extension. So this is blood vessel. This lymph node, lymphatic channels, blood vessels, extranodal extension. Cancer cells have broken through the capsule and spread to the surrounding tissue. It's a poor prognostic sign. So you want to look at all those things in the lymph node. So look at very clear-cut extranodal extension. What this question is actually, this is ANE from your IHC. What the question is trying to tell us is that you can't know how that tumor look like. After neoadjuvant chemotherapy, if you come and remove a lymph node and looked at it and you say ITC, you cannot tell the degree of involvement, whether that lymph node had 10 millimeter deposit or not, because you have to measure the size of the involvement, the size of the deposit, whether that lymph node had extranodal extension or not. You can't. You only just know that there was prior tumor. That's all. But I cannot tell you the degree of pre-treatment involvement. Pre-treatment burden can't be inferred. Hello, sir.
I'm with you. Yeah.
Very good. So number
Let's
10.
move on.
What element is not required in reporting for patients undergoing primary surgery without neoadjuvant therapy? Pick up your pen. Fibrosis. Fibrosis is only used for patients who are undergoing neoadjuvant therapy, right? So we don't use that for people who are undergoing people. Even adjuvant therapy, you don't report for fibrosis. It's only for patients who have adjuvant therapy. What does CMO-M0IT indicate?
No, it's like circulating tumor cells. No clinical
metastasis, like
no clinical metastasis, but isolated tumor cells.
Yes, there's no metastasis to specific tissues that we know, but in the blood, there are isolated circulating tumor cells. Metastasis for metastasis. CM0IT. Then Question number 12. In breast cancer reporting, with adjuvant chemotherapy, fibrosis must be distinguished from what?
The true residual tumor cells.
The adjuvant chemotherapy commonly leads to which histologic lymph node feature if primary metastasis existed? Yeah, pick up your pencil. Fibrous scans. The white prefix indicates receiving adjuvant therapy. Lymph node demonstrating only fibrosis. Post-adjuvant therapy will be classified as what? Negative node. Pick up your pencil. So this question you call the answer C, I call it E. Well, let's see. I see that.
Okay, this is the next question. All of the fun.
Yes, we already answered this question before. But let me. Let's.
What's their own explanation? I'm interested in their own explanation too.
Yes, we should do the own explanation usually as the second one, but I wanted to. Yeah. I told you, don't play with saliva. Did I have told you before? Don't play with saliva. I told you, don't play with saliva. I want to be a dirty boy, Alan. Don't play with saliva. Right? Clean it. Clean it. See? Clean it. Okay, so. Eba. It's in a trash. Don't play with saliva. Yeah. Some people say, so let's quickly discuss this. I get this in hand. I don't know what's happening. Is it my system or it's just so recurrent breast cancers. So the answer, okay, you are right again. Answer is C. Most patients who experience the original occurrence do so 2 years after primary breast cancer resection.
That's not even what I took.
What did they choose?
Well, no problem.
But then I chose D as a positive margins in the breast cancer. I don't remember once. I think I mixed up the question again. So let's really see that. Let's choose that and see that the answer. Yeah, it's most likely because this is a text question. Now,
what's the answer?
The answer about recurrent breast cancer is this. It says that most patients who experience locoregional recurrence do so greater than 2 years after primary breast cancer resection. So most patients who experience locoregional recurrence do so within 2 years. The greater the time interval between the initial diagnosis and the locoregional recurrence, the more likely it is that the recurrence will be located in the remote area of the breast. What does that mean? Can you explain this difference?
Yeah, the more likely it is the corona will be located in the remote area of the breast.
Do you understand what it means?
That means that you have an initial diagnosis, and then maybe they have done surgery or whatever. Then there is now a recurrence.
What do you mean by remote area of the breast?
Remote area of the breast. That's actually the issue. I don't know. You can find out. Maybe an hidden area or something.
Yeah, so understanding locoregional recurrence patterns, timing of recurrence. Locoregional recurrence refers to the return of cancer in the same area where it first appeared, such as breast, chest wall, or nearby lymph nodes. So if a tumor recurs in the same breast and maybe the same quadrant, that's called locoregional. Local means the same location, regional, the same region. Locoregional recurrence. Instead of recurring in a different breast, the tumor may recur in the opposite breast. For instance, but that's metastasis. But this is local regional recurrence. So most patients who will experience this type of recurrence do so within the first 2 years after the initial diagnosis and treatment, usually surgery. After you remove the surgery, a breast tumor, then it comes back to the same breast in whom you have removed the tumor. Why? The cancer cells that cause early recurrence were likely already present at the microscopic levels during or right after the initial treatments, but weren't completely eradicated. That means the surgeon did not completely take out everything, so it will grow back. These cells grow and become detectable relatively quickly because they are often biologically more aggressive. Time interval, and location of recurrence. If a recurrence happens later, for example, several years after the initial diagnosis, it tends to show up in a more remote part of the breast or chest wall. Why? The longer disease interval research suggests that the remaining cancer cells were few, less aggressive, and slower growing. Remote means maybe away from the area it first appeared. Sorry. So if it occurs within 2 years, short years, it's more aggressive. If it occurs after several years, it's less aggressive. But they will over time, the tissue environment changes due to aging, treatment effects, or other biological factors. And when recurrence eventually happens, it may not be confined to the original tumor site. Instead, it can appear further away within the same region, often making it harder to predict. So the clinical application is this. Close surveillance is particularly important in the first 2 years after treatment. Later recurrence require a broader assessment of the breast and surrounding areas because the recurrence might not be exactly where the original tumor was. So according to what we see now, most patients who experience local regional recurrence do so within the first 2 years. So that is, if it's right upper quadrant, if it recurs, it's going to be where within the first 2 years. Right upper quadrant. Right outer quadrant, for instance, right outer quadrant. And those are because the tumor was not completely removed during surgery. What is this? But if this tumor recurs like 10 years later, it's not likely to be in the right upper quadrant any longer. It's going to be in a remote area. For example, remote area is now left lower quadrant. But it's still the same tumor. Why? It's less aggressive, grows very slowly, and because with aging, the breast tissue changes in size. There's aging, like all these things related with aging, where they mentioned here. What are the biological factors like aging, treatment effect, many things. The breast shape and everything will change. So it may end up now appearing in a different part of the breast. That's remote appearance now, and may still be the same tumor. Here in the US and the UK, they keep records of patients for donkey years. So you see a patient 10 years later coming back to you now with breast cancer. The first one was right upper or outer quadrant, right outer quadrant. But now it's left lower quadrant. That's a remote recurrence of this same breast cancer. That's what I'm trying to say. So in the first 2 years, we have to do close surveillance because of the risk of original recurrence. Later recurrence is more complicated. Okay, so that's all. I think that's all. So most patients who experience original recurrence do so within 2 years. The greater the time interval between the initial diagnosis and the original recurrence, the more likely it is that the recurrence will be located in a remote area of the breast. Okay. Do you want to read through this, or it's very long? Or should we just go ahead to review it immediately?
Just glance.
Okay.
But can we read even the ones that are wrong to check why they are wrong?
Yeah, I used to put it in the review. Okay, but let's read it. Just that I feel that by the time we keep you now, we'll actually it will take us much more time. But let's continue it.
That will be fast with them.
Number 9. B. And this is true. Okay.
Wait, let me see the question again. Let me see the original question.
It's except, yeah.
Except, Jonah, because you know what happened? I was like, most of the answer are looking true.
Yeah, they're actually
You
true.
understand?
So yes.
So let me now. Most of them will explain. They do so within the first 2 years, within,
Yeah,
not
not after
greater.
2 years.
So
Yes.
if it is
So
within, that is true.
it's going to be in local regional occurrence. But if it is after 2 years, most likely it's going to be a remote location, no longer local regional appearance, except local regional something.
Okay, I think I got it.
Okay. We'll quickly go on our review. Our reviews actually makes life easier and faster. Without I'm putting all the essential points we need. Okay. So we'll go for a short break, 5 to 10 minutes. Then I want to quickly put some food together. I want to come back, but once we come back from that break, oh sorry, when we come back from that break, we'll answer these questions. These questions are fast. Less than 5 minutes we can. Oh, good. Okay, sir. I'll quickly make some food now. I'll be back shortly.
Okay.
Hello, sir. Sorry, are you back?
Yes.
Sorry, we're preparing food. I am back.
Okay, I'm back.
Can you read the questions for us?
Which which of the following factors increase the risk of locally recurrent breast cancer after breast compensation therapy?
Surgical margins.
Yeah, toxic surgical margin.
That is strong predictor of local regional recurrence.
Most patients who experience local recurrence do so within 2 years. Within 2 years. Early
Yeah, within 2 years
recurrence
of
most
primary
common.
surgery.
Potential work progression.
Yeah.
Lack of radiation after lumpectomy may increase the risk of local regional recurrence. Radiation is prescribed after breast conservation to prevent local recurrence. Then extensive intraductal carcinoma is associated with increased local recurrence. Okay. 5. What histology type of
You
recurrent
didn't
heart
read this part.
defect?
Excessive DCIS also increases recurrence risk if margins are not clear.
Yeah.
We should just look at DCIS margins in our CAP report. Look at this. Look at DCIS. Here, the B is on top. They'll ask you at the bottom, top. Margin status for DCI is very important. Distance of the DCI to the closest margin. So if margins is close to DCIs or DCI is positive for margins, increase the risk of local regional recurrence as well. And continue.
What histology type of recurrence has the best prognosis after cervic mastectomy? Ductal carcinoma in CI2. Non-invasive recurrent have present prognosis after cervic mastectomy.
What is cervic mastectomy?
Well, maybe to preserve some of the breast tissue, you can check.
Let's do this one in page 44. Draw a line to match the pictures. Draw a line to match the picture.
Okay. Wow.
Look for this type of caps here. That's the second surgery after the main surgery. We'll treat your recurrence.
No, when you have done a conservative surgery, you understand. Then if there is not recurrence, then you need to not do totally to completely remove. Maybe before you don't want to remove the breast. You just do, but because of the recurrence now, you have to remove everything.
Okay. You have to salvage mastectomy. If only what is left is a DCIS, then the patient has good prognosis. Do you understand? If after a salvage mastectomy, if only what is left is DCIS, then the patient has a good prognosis.
Sorry, can you repeat?
You know, after a salvage mastectomy like this, you look at it again to see if there's cancer.
Okay.
If you see invasive ductal carcinoma again after salvage mastectomy, that's not good. But if what is left is just DCIS, that's good. Look for it from up. You understand?
Okay. Sorry. Yeah, I'm back. Yeah. Hello.
So normally when we do surgeries, salvage mastectomy, you will be looking, maybe there's a recurrence after the main surgery, radiation fail, lumpectomy fail. If what is left after the salvage mastectomy is DCIS only, that's good prognosis. Excellent prognosis. But if it's real cancer, that's not good.
Okay. Same condoms. Which type of organic is most common? Same color as original tumor. Most color are the original tumor cells, suggesting complete resection. Okay. Which recurrence pattern is associated with poorer prognosis? Diffuse breast recurrence. Diffuse skin involvement is or arterial occurrence correlate with worse survival. Positive margins are considered
This is an exam question. What's the positive margin?
tumor cell touching the ink margin.
Yes. Number on ink. In Nigeria, do you ink a lot when grossing?
Sometimes, or not a lot.
The US we ink a lot.
Two positive margins are found on tumor cell.
With many colors. Yeah,
Hmm?
continue. With multiple colors.
With
Multiple. So how do you determine positive margin if you don't ink?
you just look at it directly. But we do take margin.
Okay.
Mm.
Separate or separate containers, right?
Yes.
That's better. Number 9.
Do, okay. Do you put in the same container?
No, separate containers also.
Which factor improve prognosis in patients with local regional recurrence? Recurrent detected by mammography. If you improve
Mm.
small earlier detected recurrent
That means
by
that means when you after vasectomy you keep doing
mammography.
mammography to see within the first 2 years. But,
Related in this case after breast conservation are rare.
what can
Okay.
occur?
Hmm. The risk of local recurrence is highest in patients with positive margins and extensive disease. Insensitive disease. A closed margin is defined as tumor cells within 1 meter of the ink margin.
Yeah,
The one at the ink margin means that the tumor cells are involved.
it's
The margin
positive.
is above. Yeah.
It's positive, but less than 1 millimeter is close margin. How do you manage this? How do you manage close margin? Let's come and set with one that is. How do you manage the close margin? Different. I think different. Different.
Yeah, chemotherapy.
Yeah, come. Re-excision and radiation therapy boost. Mastectomy. And this one just to go back and re-excise the thing. We will see positive. We do radiotherapy. Do science. They will do dancing rice. Come on, end. What's imagine surgery? Let's finish our math. That's the one that go back. They will do science. Relaxation, radiation boost, or mastectomy. Those are 2 millimeters considered clear margin. Anything more than 2 millimeters is clear margin already. So enter you want to measure the distance to margins too. It's 4 degrees now. Okay.
Do you measure it under microscope?
You measure the microscope with ruler.
I know. Okay. That close margin, can you diagnose it under microscope?
Yes. We use ruler to measure it now.
I mean microscope ruler.
Or even ordinary ruler.
Is it why you are reading the slides or is it a
Mm.
gross thing?
We use large microscopy.
Okay.
Number 15. Are you done with number 15?
Kenya with parents after five years. Okay, yeah.
Okay, let's go to the next question.
So
Look at the
let's
nipple.
look at
Mm.
let's see the image.
What is this?
Mm,
I don't know. Okay, papilliferum, I don't know. It is classic nipple lesion. I think it's called nipple adenoma or papillary lesion. This should be a papilloma of the nipple now. This should be a
Papilloma of
papilloma.
the nipple, that will still be, what's it called? Papillary structures.
Doesn't it look papillary? It looks like papillary little bit. Let's see.
So this one may convey. Anything that is so introduced for pregnancy. I think it's D.
Yeah, this is the answer. Nipple adenoma. It's a chronic papillomatosis of nipple.
Let's look at that answer. Jonah, I prefer that we look at their own response before looking at ChatGPT.
No, because why? We have already made our own selection, right?
Yeah,
So why do we need to look at their own? Why do you suggest that? Well, since we already made our own choices, and most of all, we have different answers sometimes. So
like they are, like let's look at the author's response.
no, we should look at the
Okay.
author's response now. One immediately after ChatGPT, now I used to go and click it.
Okay.
Remember, we used to look at the author's response.
I think what the way we did yesterday was that we look at the author response, then we now copy the response and make questions. I think that's what we were doing yesterday.
Okay, you don't want us to copy the response to make questions, no?
Eh?
So you don't want us to copy the thing to make response.
I think I prefer the one we did yesterday, but then we can make go it up, sha. Okay.
We used to
Look
copy
like
the author response to make questions too. That's what I did. That's what I've been doing today too.
mm,
Mm. Those 50 questions
okay.
we answered came from the author's response too. And
Okay, okay. All right, let's go.
so actually, the answer is actually accept. So which of them is wrong? The answer is E.
Oh,
Mhm. Yeah.
so what's the answer? Because
That's E. So this is the answer. Can you read the place?
so the diagnosis is pluripapillomatosis.
Look at the diagnosis. What is it for? Nipple adenoma. Yes.
Nipple adenoma.
Mm.
arising from benign preparation arising from sub. What do they contain?
Hello, now you want to read through all this, or should we go to review it at once? Now read it. Read through.
Okay. That's very dumb. It's important.
Pick up your pencil. Let's circle the one that is different. Come. Come. Let's colored pencil.
Okay. The difference between
So circle
lymphadenoma and
the one
sphingosarcoma
that is different.
is that sphingosarcoma lacks epithelial proliferation and is not associated with ductal structure.
Okay. You want us to review it, or we should go ahead to the next question?
Okay. We can review it.
Circle the
Then to increase our speed, maybe we can reduce the number of questions from like 15 to like let's say 7 or 8.
Obey your. The thing is that actually, well, the review of those questions don't usually take time. If you notice, sometimes in 1 minute you
Okay,
can do like 3 questions
that's
if you
true, sir.
remember.
That's true.
Yeah.
That's true.
Because we would have dealt with the main subject, reviewed it, then this was just like a brush up to.
Okay, let's move on. Yeah.
Let me quickly. Once I start generating, we'll go to the next question, and then. This question is like except because it's a study question bank, not a real question bank like this. I don't know. Go to the next question.
Let's look at it. The lesion identified the name is described by all of the following. This is Paget disease.
Yes. Oh no, who will sit down now? Right. Here. Circle the circle the different one. So which one is different?
This one as
This one is number one.
the adenoma.
I'll choose E. Different. Circle it. Go
Florid.
round and round. Sit down. Sit down, Joe. I'll be begging you sit. Sit down. Sit down here. Come and sit down.
Okay, let's continue.
Okay. Now, so I'll choose E for instance. Okay, let's go.
Okay, have you which one? Have you done deletion risk? Okay, I've not done this one.
This is a new question now. We just finished this question.
Okay, I thought so. I wanted to.
Let's go back to the other question. I quickly review it quickly.
We have already okay.
Sit down. You are using it to play since.
Okay.
Sorry. Close your mouth. Which one is different? What's a minute, please? Sorry. Flurry papillomatosis of the nipple is also known as
nipple adenoma.
initially depicted as flurry papillomatosis, which histologic pattern is commonly seen in flurry papillomatosis of the nipple. This one, this one, this one.
Cellular formation and adenosis.
White. What color is this one? Hyperplasia, papillomatosis, and adenosis. What color is this? Which feature excludes invasive carcinoma in flurry papillomatosis? What color is this? Eh? What color is this?
Multiple epithelial cells.
Yes. Flurry papillomatosis may histologically mimic which of the following? Gray.
Syringomatosis adenoma.
White. So what was the difference between the syringomatosis adenoma? This one is what? This one is what? So which one is different?
Okay, yeah.
Which one is different?
This one, you see,
white, and
papillomatosis and things like that. But syringomatosis, what's it now? It's just epithelial cells. Epithelial cells that.
So which one is different here?
They did explain something there. Okay. Maybe although it lacks epithelial cell proliferation, I know I said with doctor structure as opposed to
come and sit down. Using if we have a picture of syringomatosis adenoma, let's look at it quickly. Let's look at syringomatosis adenoma. Which one is different? Which one is pictures? Different? What color is this nose? What color is this nose? What color? What color is this nose? What color is this nose? What color is this nose? We'll get it quickly now, sorry. What color? What color is this nose? White. So which one is different? White. Black. Maybe I've taught you the same and different before. Eh? I've taught you the same and different. You still need to come and then you'll be playing up and down. Number 3. Look at it now. This is the adenoma of the nipple.
That's what they say. They like tadpole-like cells, something like that. Tadpole-like.
They have comma-shaped or teardrop-shaped ducts.
Yeah.
How many eyes does this one have? Look at it. Eh? How many eyes are here? Look here. Which one is different?
Then focal or squamous cell metaplasia.
Look here. How many eyes? Squamous cells there. 2. How many eyes? Keratinidase or squamous cells. No eyes. There's no eyes. How many eyes is here? 1, 2. How many eyes are here? Oh. 1, 2. How many eyes are here? 1, 2. The adenosis which form can make multiple adenoma. So multiple adenoma may be in the differential, though it lacks epithelial proliferation. Eyes. So this one is different. What is true regarding necrosis in flurry papillomatosis? Number 4. It may be seen with carcinoma. So which one is different here? Even in benign ones, okay. Extension of epithelial cells into the epidermis in flurry papillomatosis may mimic what? This is a wall gecko. Which wall gecko is different? Look here. Which wall gecko is different? Number 7. Which local help will typically native in flurry papillomatosis simulating Paget disease?
Which one is different?
This one is
has
white back. This one has black. What are the markers for Paget disease? White back.
CK7 ER estrogen receptor CK7 epithelial marker like CK7 estrogen receptor. We can also do an atenin too.
Atenin, yeah. See, I see the number. So CK7, yeah, CK7 is a very big marker for pages. L2 EMA, CEA. There's this G6DFP50. Which butterfly is different?
Those is the same people.
I'm shooting marker 88 marker P6 400 HMB 45 Pelan A man shooting markers are negative P63 my last negative 65 negative. Or you can 7 2 new frequently positives. Which one is CK7 EMA? Sometimes this disease, pleuropapillomatosis, or nipple can spread to the nipple skin. Look at the example patches. So how do you differentiate it? We do Paget markers.
You do CK7, you do atenin.
Yes, I had to. S100, S100 is normally negative, so it's not useful. S100, CK5, CP, these are all negative normally in Paget. CK7, J2 new, AMA, and J6, DP, GCD, FP 15. Okay, very good. So it will be negative in this case. So that will make you do differentiating from which one is your right hand? From the condition. Show me right hand. I'll put it now. Your right hand. Budget. Look at the following lesions should florid papillomatosis be distinguished from due to similar histologic features. Right hand. Left hand. Okay.
Sclerosing duct hyperplasia.
So barilla sclerosing duct hyperplasia. We saw this earlier. Remember? You remember where we saw it earlier? In radial scar.
Okay.
You see, radial scar was found inside the breast, but this subareolar sclerosing duct hyperplasia is usually found close to the nipple. So it can also mimic nipple adenoma. So how do you differentiate the two? What do you think? How do you differentiate the two?
Differentiating from
Subareolar. Can you call the entity again? Can you mention the name of the entity?
okay, subareolar sclerosing hyperplasia.
Subareolar, that is beneath the areola of the breast. Sclerosis, you can see sclerosis, duct hyperplasia.
Okay.
This one has both papillary structures and this one is different. So how do you differentiate the two? So let me see a quick panorama, just very short one. So it's logic differences between the two. For florid papillomatosis, papillary proliferation will be prominent. That's when I said that it looks like papillary formations. That's what I said, it looks papillary. Papillary formations are less. Sclerosis is more in this one because it's subareolar sclerosis duct hyperplasia. Ductal proliferation is found in both. Shielding for the found in both. So the difference is the location. This one is subareolar, nipple and subareolar, papillary front, ductal front. Fibrosis is more here. Then when you do ahexis, doesn't help. Invasion doesn't help. Epithelial atypia doesn't help. I would say where papillomatosis with more connection to the epidermis, I will have more glandular and papillary structures. While the other one, SSDH, is going to be deep-seated under the areola without epithelial involvement. This for florid papillomatosis may involve the epithelium at times. Looking like Pagets. You have two more baskets that are full. Have you seen a picture of subareolar sclerosing adenosis before? One more basket that is full. This is empty. Sir? So look for one more basket that is full.
Sorry if I can do so.
This is empty.
Have I seen it before?
Picture of subareolar sclerosing. This is what? Subareolar sclerosing duct hyperplasia before. Which basket is?
No.
Look at the picture here. It actually resembles papillary. This one is adenoma, nipple adenoma.
Okay.
It has papillary structures, but and ducts probably. So I think it resembles it. IHC will not help us.
Okay.
It resembles it. Actually, the thing that is deep seated under the areola, another one is close to epithelium, skin epithelium.
What's
Look
the
at
name
my
of this
blue place.
entity again? Subarachnoid sclerosing duct hyperplasia.
SSDH. It's a close differential of it. Okay, let's continue. The most common location of SSDH is where?
Subarachnoid
Yes.
region.
Which component is important to assess nipple biopsy to rule out invasive carcinoma?
My epidermal layer around duct.
Yeah, my markers, P63, nothing. In rare cases, carcinoma involving arising in foreign papillomatosis is typically which type of carcinoma?
A carcinoma from Dr. Carcinoma Institute.
Yeah, this can arise from nipple adenoma. Which of the following best describe florid papillomatosis of the nipple? There's both hyperplasia and adenosis.
Mm-hmm.
Okay. Which immunostain is used to highlight monoepithelial cells?
This is my epidermal P63.
What kind of marker is P63?
Nuclear marker.
Very good. In the setting of a suspected paget-like extension of florid papillomatosis, what test can help to differentiate the two?
Actual overexpression.
Two new IHC. What other IHC can be used?
ER. Estrogen
CK7
receptor.
or CK7.
CK7, yes. CK7. Oh,
CK7, this is for digits. Which of the following statement is false regarding papillomatosis of the nipple? It doesn't have mucin pool, but necrosis can occur without malignancy. Evasion is suggested, leaving my epithelial layer is absent. It may extend to the epidermis and mimic pages. Very good. So now this question that we answered before, we left off. We answered these questions already, and we all agree. Me, I agree that my answer is E. But what was the answer again?
the relation identity is characterized by a lot of following except, let me look at
I
it.
think anytime we change we go back and come, they alter the questions. Is C.
They alter the arrangement of the answer,
Yeah, yes. Okay,
but
I'm
it's
going to
still the
answer.
same. It's still the same answer. The
Yes.
relation identity is described by all of the following except clinical image as erythemas. Wait,
Sorry,
wait.
sorry. I'm listening.
Includes the cryptocurrency one the similar regress content. And possible. Maybe I'll just say C, but let's see what's their own answer.
Yes, yes. I'm thinking of C too. Thinking of C too. Let me see this
C.
one answer. Let's be the next question. While waiting for this to respond. What what of the following what of the following statements regarding gene expression profiling based classification of breast cancer is true? Can you read which of
Have
these
we finished
statements
with
is?
that one first with the one with the number 8?
No, I'm not finished with it. I don't know why I'm having some problem with my browser. Let me
What about their
why
own answer? Can we look at their own answer?
we have not choose selected an answer yet. We're not selected an answer yet. I want to look at what ChatGPT will say first before I select an answer. We have selected our own answers, right?
Hmm.
Yes, both of us selected the cells cannot contain melanin as the answer. Understand? So I wanted us to I don't want to fail the question. That's why I normally check with ChatGPT. But this is an open book exam. And if open book exam, I don't want to get low score.
Okay, can understand you now.
You know,
Okay, when you tick it now, when you select it now, it will show in your record.
yes. All my records, everything shows in my record.
Okay,
It
okay,
goes
okay.
directly to my
That's good.
project
I
manager.
don't understand you. The organizer say cannot contain melanin. Yeah.
Yes, we are both correct. And then we can now select it. And so you can read through the teaching points quickly. Now, the lesion shown is partial disease of the nipple, where right, it is characterized by large field staining neoplastic cells, which is the epidermis.
Like
Partial
skin
cells can
properly.
contain
Melanin pigment. Toka cells. Power disease.
so here too is actually what they use a lot to differentiate Paget from other mimickers of Paget. Okay. Are you done with reading this, or should I? You can
Okay.
read now.
Okay. Let me just. Toka cell may be present. Yeah, let's continue.
Give me the marker and the pencil. Done.
Mm-hmm. Yeah.
Okay. Let's go for a quick review. The reason about the review that the review actually sometimes bring out points that you may have read but have not processed very well.
Hmm.
Because the truth is that this ChatGPT knows more about how to word these questions and what you need to know sometimes than we that are just new in the field. Because it's copywriting, so go and copy all previous questions about those things. Let me just drop my food plates and come in 2 minutes. Oh, that's too much. Let's put one colors. Let's put red. First.
Essentially. Okay, move on.
Yes, it's not gonna good. What is the
Mm.
histological mark of Paget disease of the nipple? The doctor can not attend the PM. It's not clear. Oh, I hope it's okay. Okay, let's go to
Continue.
it. Okay, it's not scrolling, but let's wait a few more seconds. It will scroll. While we're waiting for it to scroll, what is Bowen disease?
There's like s- uh, spearheads, like what's it now?
There's squamous cell carcinoma inside too.
Yes.
This is kind of skin cancer. Slow gray, reddish purple. Diagnosis is confirmed by skin biopsy, typical keratinocyte. Let's see pictures, please. Pictures of Bowen disease. They bring me the dermatology pictures. That's what they will do. Unless I tell them specifically that I want histology. This is the time they bring gross pictures too in them part. That's the thing. Like purple, the histology pictures. Histology pictures of it. Oh, histology pictures of Bowen disease. You know that because it's everything occurs in the epithelium, so it may kind of mimic
Yeah, in the
Paget
epidermis.
disease. Yes, well, how we differentiate Bowen disease? You can see these atypical nuclear cells, but that the way you know that how do you differentiate Bowen disease from invasive carcinoma of the skin?
We could use Atunu.
No, that's the differentiation from Paget disease on H&E. If you're looking at how do you know that this is not invasive carcinoma of the skin, squamous cell carcinoma of the skin, but it's Bowen disease. It's still inside too. It's not yet invasive
And
cancer.
in Piquet disease, you will see the typical epithelial cells, large, promorphic. Sometimes they may show some
That's also
flaws.
found here. This is Bowen disease, and it has pleomorphic cells, hyperchromasia, significant pleomorphism. You see mitotic field. This is all features of cancer. What do you differentiate it from invasive cancer of the skin, squamous cell carcinoma of the skin?
Okay, what do you think it is?
When you start seeing breakout nests, they start detaching from the surface. That's invasive already. If everything is still attached to the surface, it's not
Okay, I
detaching
thought
from the
you
surface.
said but I thought you said distinguish squamous CIS from Paget disease. That's what I thought you said.
No, that is too new now. That you use for that. Okay, no problem. Okay,
Okay,
so this
with
is
invasive. You're
yeah,
asking different invasive. Yes,
yeah,
there will be focal of impatience.
yeah,
Breakout
very
nesting.
good. There will be some breakouts. It's here. It's still full thickness atypia, but it's not yet forming nests. Full thickness atypia, not yet forming nests. Full thickness atypia still connected to the epithelium. Full thickness epidermal atypia with disorganized architecture, abnormal mitosis, descriptive involvement with an intact epidermal junction. So it's not yet forming nest. So let's come back. Finally, it's ready. What is the histologic hallmark of Paget disease of the nipple? We talked about that. Which thing is typically positive in Paget disease?
Which thing? CK7?
Yes, it strongly states it helps to distinguish melanoma from Paget disease or Bowen disease. So CK7 it distinguishes them from melanoma. HMB 45 positive or Bowen disease. Bowen disease is actually negative for CK7. What is the marker for squamous cell carcinoma?
Squamous
What is the
cell
IHC?
carcinoma.
The standard IHCs for squamous cell carcinoma?
Pan-cytokeratin?
No. Like the clear cut markers for squamous cell carcinoma.
Which one now?
P40.
P63?
Yeah, P40 is cheap. Okay. Including Bowen disease. So you see P40, P63. Okay. As long as you see Um, P63 is nuclear stain. You know that the good thing about P63 is nuclear. Nuclear stains are cleaner than cytoplasmic stains. I think P40 is like cytoplasmic, but one of them P63 is high sensitivity, CK56, AE1, pack circulating to EME, uh, bowel disease, everything, all these things will be positive bowel disease. So for S1 sorry, they like A will be negative, S1 will be negative, B and P4 negative. Here, two new is what we use to differentiate. Now, P40 is now the most specific marker for squamous cell carcinoma. But hypophysis negativity is extensively useful to rule out basal cell carcinoma. Basal cell carcinomas will normally have
Not this
hypo4.
is because chemosecond. Usually to rule out basal case carcinoma. Yeah.
Bear hypo4.
The EP form.
Good H and E is still what you need. These are all adjunctive things. Good H and E. Okay, good. So
The EP form.
budget disease you use CK7 on head soon over education. Number three.
Share for the pelvic marker. Atenine.
Well, do
Total
you
cells.
do you know what we are actually doing in essence?
Hmm?
Do you know what we have been doing so far?
Yeah, just to reinforce.
Bread and butter, breast pathology, what we do day to day. Do you know that this is what we do a lot in the place of work? We have not really been doing esoteric breasts. So I don't know why.
Mm,
Anyway, but if you master this, you can work with this. Then you can now on your own grow to know more difficult things.
mm,
But if you don't know these things, you can't actually function as a pathologist. You can't.
mm.
These things are what you need that to put bread on your table. Okay. But some people will think it's too simple. But if you don't know it at all, actually, you're not even a pathologist. I'm glad I'm reviewing it. I'm kind of, I don't want to say I see it a lot of time, but I'm kind of getting more familiar with it now. I'm glad. Now, Toka cells. What are Toka cells?
What are they? They are non-neoplastic, benign clear cells of the nipple epidermis and lapiomorphism.
Let's look at the picture of Toka cells. Toka cells of nipple.
That's a
Toka cells. You see, the picture is what? 1,000 words. The example pages mention disease of the nipple. But they're not, how do you differentiate on pages disease of the nipple? They lack what?
picture
They
disease
lack
of the
pleomorph,
nipple.
they lack pleomorphism.
No, wait for me.
No,
Wait.
yes, the total cells lack pleomorphism because they are normal cells.
Yeah, they're not no plastic cells.
Come on, wash your hands.
But when you do IHC, what IHC will differentiate from Paget
Atenine.
and CK7? Okay. Look at them. They are cells, they almost resemble keratinocytes sometimes. You can see they have white surrounding, white clear surrounding. Look at them here. These are Tucker cells. You see, someone will see them and think they are Paget disease. True. If you look at this now, let me make it larger. Sorry. You see this? It looks very white, and it looks like Paget. But when you do the two new, it will be negative. It will be negative. Sorry. Let me put it back to good. Now see them, Tucker cells. They don't have this hyperchromasia, necrosis, hyperpleomorphism, INC ratio. They don't have all these things. Tucker cells. This one even looks very. It's actually Paget disease. It looks mucinous. There's mucin staining. There's mucin in Paget disease at times. Oh, that's by the way. So, question number 5. Which differential diagnosis involves malignant melanocytes?
Normal.
Melanoma can malignant melanocytes.
You can use continue.
Which immunostain helps to distinguish Paget disease from melanoma?
Well, okay, CK7. But okay, will that be 8.8 for HMB45 to
What are the
Suxten
mark-
S1?
Okay,
Okay,
very good. What are the markers for
Paget.
melanoma?
Hmm?
What are the markers for melanoma?
HAB45, S100, and SOX10. But
For the 5
but
800, but
but I
that's A
think that
also.
Paget disease also could have some melanocytes, so maybe that's why they choose CK7.
Yeah. Let's see. There was something like that earlier on when we saw something like that. Let me see. Let's got we say it. Um, let's leave it there. So that's what you can associate the two using CK7.
In Paget is sensory mucin. Okay.
We saw mucin in the last Paget disease we saw. Remember?
Okay.
Look at
Yeah.
this. If you
Yeah.
look at this is mucin surrounding the nucleus. So this is favors more of Paget than Bowen disease.
Okay.
Okay.
Maybe
Number
present.
8.
Food translation will not be expected to overspread anemia. Coca says.
Yeah, Paget disease cells react to Tucker cells, no. Progressive
Mm.
ductal carcinoma of the breast. Yes, luminal B. Paget-like cells. So you're right, Tucker cells. Say open, please.
Press up, please.
Thank you. Now, okay, we go that science experiment. So now, number 9. So let me pick up my baby. So which lesion clinically, Paget disease of the lymph may be make what?
We will talk about dermatitis and the terminal constellation replacement inflammation.
Okay, the eczema dermatitis. Paget disease often presents as an erythematous cluster lesion and no inflammation. Which of the following is least likely to be part of the differential diagnosis for Paget disease?
Dermatofibromatosis protuberans.
Yeah, Tucker cells is a good differential because of how white they are. Bowen disease also, melanoma also. But dermatofibroma protuberans is not, it affects deep damage. I thought it is. No, it's a deep dermal problem. It's a deep damage issue. So dermatofibromatosis is a soft tissue now. I think when we get to soft tissue, DMF, dermatofibroma, some DFSP, DFSP.
Yeah, which is
So that we'll get to soft the bone and soft tissue. Now, we're going to run straight to the next hour. Then we'll go on 1 hour break. I can have a meeting, just 1 hour meeting. Then we'll come back if you don't mind. Then we'll finish up maybe
okay.
2
Yeah.
hours.
I
We'll use
want
that
us
time
to
to
also
rest
have
a
like
bit.
that 5 minutes break. I want to
Okay,
take some drink.
perfect.
Let's finish
We'll come
this
back
one. Then
in.
have 5 minutes
Okay,
break.
very good. Which immunohistochemical marker is also positive in Paget cells, similar to CK7?
GCDPFP,
15. No, we mentioned it. What are now? Let me mention all the markers that are positive for Paget disease.
CK7 are 2 new, GC,
CK7 had 2, GC,
FP,
GCD,
FP15.
GCD, then FP15. GCD, FP15. GCD, FP15. IHCs for Paget disease. A lot of times you have to repeat something multiple times in pathology before one can even think of mastering it. True. I don't know if it happened to you.
Yeah.
So this one thing you have to repeat it over and over and over and over again. Otherwise, it doesn't stick. Sorry. GCD FP15. Look at the next one. Number 14. Paget disease of the nipple usually originates from where?
Delta carcinoma in situ.
Number 12, sorry. Which histologic feature differentiates Paget disease from Barren disease?
Missing.
Mucin. Melanin pigments in Paget disease may lead to confusion with what? Number
Which one
13.
now?
Number 13. Number 13.
Many people confusion with melanoma.
Yes. So that's why we do CK7 and HMB and HMB45. Paget disease of the nipple usually originates from where?
Delta carcinoma in situ.
Of the breast that is spread to the skin. Yes. Which of the following statements is false regarding Paget disease of the nipple?
Missing. From C. Melanin pigment rule out Paget disease.
Yes, melanin pigment does not rule it out. Because some Paget disease may actually acquire melanin pigment. Doesn't mean that it's melanoma. Okay, let's go on 5 minutes break. We'll be back in the next 5 minutes.
Let me
Thank
give 10
you.
minutes. 10 minutes.
Okay, 10 minutes. Okay. Thank you. We're using the computer to pause music. Let me pause the recording. Okay. So we can actually pause recording. I didn't know that. Okay, we are resumed recording now. Unfortunately, it's okay. It's fine. Okay, let me go to the review of the questions then. Quickly. Question. While waiting for it, can we answer this question?
Yeah, which of the following is part of the CAP ASCO Ghana for undergoing should be free for the assist to is part.
I'll say B. Labor in our program.
Actually, because it's good, because if greater than one place says sure, because this is started also during students is based on greater than 10. Mm-hmm.
You know that in my program, normally for breast cancer, we don't, every breast cancer, we must make sure it enters formalin within 1 hour of removal from the body. Call it the cold ischemic time. It must enter formalin, sorry. I don't, do you have a program? No, when you do breast cancer surgeries, do you normally do breast cancer surgeries in your center?
Yeah, they do.
What days of the week?
I can't remember.
But do they have any agreement with the lab to put the breast cancer in formalin immediately they remove it?
That's the ideal, though. That depends on if they that's the normal thing to do. You understand?
Well, before you put it in form, you don't put the whole breast cancer inside formalin. You have to prepare it. Do you normally prepare specimens for putting in formalin, like cut it into tiny bits, ink it and cut it into bits before you
No,
put it in?
the thing is that the lab supplied the bucket, the formalin buckets, depending on the surgery type. You supply the theater with formalin and the bucket so that when they do the surgery, they'll put it there and now bring it down to the lab.
Well, do you start working on the breast tissue immediately, or do you wait?
No, we wait. You wait till the next cut-off day.
At least is a big crime to do that. Once the tissue is removed, whether it's in formalin or not, you have to bring it to the lab fast. Sometimes
Are
we
you
don't
the
go
one that
home.
will bring it or the lab people?
There's a courier service that brings it. Sometimes, if you have a breast cancer surgery that's running late, the resident that's on call will not even go home, or the resident that's in resection will not go home. We're waiting for the breast. As soon as it arrives, you pick it up and prepare it. To prepare the breast cancer, you ink it depending on the quadrants and everything. If it's mastectomy, if it's lobectomy, you ink it into 6 colors. Then after you ink it, then you now bisect it. You look for bisect it, take photographs of all the bisected skin. Of course, you will take X-ray, take photographs, label where the clips are, everything. Then you now fix it in formalin. That's it will now be properly fixed because you have sectioned it small. And obviously should be done less than 1 hour. That's good. Is clinic time less than 1 hour.
Okay, so you ink the margins, then
Yes.
you take pictures.
You take X-ray, fasciculation X-ray to look for the mark, the clip. Then after that, you ink the margins. After that, before you wait also, you now cut it into 2 millimeters, into 3 to 5 millimeters thickness, depending on whether it's lump. If it's mastectomy, because we call it like 5 millimeters thick. If it's lumpectomy, 2 to 3 millimeters thick. You cut it. How you cut it now? You take photograph of the cut surface of the tumor. You look at, because of course we do photography too, to look at the tumor, the size of the tumor. The picture graph will show the size of the tumor in relation to the inks, everything. You don't need to do all the measurement, just take a quick photograph, then wrap it and put it formalin. So that way you increase the surface area where formalin penetrates and fixes the tissue better. And also it makes it very, very well make it good for the tissue to be well fixed for immunohistochemistry and for molecular testing. If the cold receptive time is very prolonged, it makes molecular testing to give you bad results. You don't have very excellent results with molecular testing and all that.
Okay. Yeah.
Anyway,
What do you use to take the pictures?
we have special cameras in the grocery room. You can take photograph. Very good cameras. I mean, like it's a camera station, like it's a camera station. The way you have a glassing station, there's a station for camera. You just put it under, take the photograph. It will, and of course, you put in the accession number. It will automatically upload the photograph into the patient's anatomic pathology laboratory information system. We use all these laboratory information systems. You don't use paper. You use laboratory information system, please. Like all these intranet kind of
And I've not started
computer.
practicing. I've not started practicing in the UK. We use paper in Nigeria.
Paper. You see, we don't use paper. So there we use all these. The photographs will be uploaded immediately to your laboratory information system.
Okay.
I think we can build a hospital that can have a laboratory information system in Nigeria and all that. That's what we are trusting God for in the
People
missions.
already start. Some hospitals they're already using all those things now.
Yes, in Nigeria, yes. Many of them. All of usage.
The only thing we can be thinking of is the lab.
What of usage?
I'm not sure they're using the usage.
Well, we are trusting God to build this thing in the missions. So maybe when we are ready, you will join us. Yeah? We want to be the teaching hospital in the future. I don't want to build this much. Thank God. Anyway, let's continue. So, gene expression profiling in breast cancer primarily focuses on which clusters?
This is a good point, but not completely.
Yeah, what? Kitchen.
Sorry.
This place is a kitchen.
This was the questions we're trying to generate before we went to the new question.
Okay, let's look at it. Gene expression profiling in breast cancer primarily focus on which clusters? Estrogen receptor proliferation and to related application. Okay.
So the gene expression profiling is based on what form of axis? HER2 related amplification, estrogen receptor,
Proliferation, that's KI67.
Yes, but let's see if we can explore this more. I don't really understand this issue very well. Okay, the next question. Sorry. We put the system. Sorry. Why is this difficult? Sorry. So let me see if we can explain this question in simple terms. I want to be sometimes if you don't understand something, you just overlook it. You may see come and encounter it in the future. Gene expression profiling means checking which genes are turned on or turned off in breast cancer. So that's the meaning of gene expression profiling. want to profile what genes are turned on, what genes are turned off. When scientists studied many breast cancers, they found that cancers naturally grouped into clusters based on the patterns of gene activity. The three main clusters that they look for are estrogen receptor, proliferation grade 3, which is KR67, and HER2 related amplification, HER2 amplicon. Why not other choices? Okay. So based on research, the genes we look for to look at tolerance estrogen receptor, KR67, and HER2 related amplicon. Okay.
Which then? One.
Okay, good. Which of the vaccine? Which of the following best describe lobina A tumors?
Which of the following? Let's see. Low
Yes.
proliferation, good. That's ER receptor positive.
Yes.
R2 negative.
positive, HER2 negative, yes. KR67 low.
Hmm.
Gene expression profiling and immunohistochemistry classifications.
Okay. Primary overlap, but not completely.
Discordance of protein. So what's gene expression profiling then? And IHC. Can you explain that point?
The primary overlap, but not completely. Let's say for a particular, tumor now. Let's say tubular carcinoma. You could do the the IHC, like let's say ER positive, PR positive, R2 negative. And then when you now do the gene expression, it could still be the same thing. But in some cases, they may not be exactly the same. That's where I understand it.
The thing is that I think maybe they do that here 2 new 2 plus. That sometimes it becomes a people count. It's IHC.
Continue.
That's all. Okay. So let's look at this quickly. So how do gene expression profiling and immunohistochemistry comparing breast cancer? Gene expression profiling checks which genes are turned on or turned off in cancer cells. IHC uses special stains to detect proteins like we have HER2 enriched, basal-like triple negative. Most of the time, the results from gene profiling and IHC match. Sometimes the proteins don't exactly mark the gene signals. That's what I wanted to explain. Why are they not? What is the profile of HER2 enriched?
R2 enriched, that means it's R2 positive, ER negative, and I think it could also be PR negative too. And IKI67. ER negative, but IKI67 and R2 positive.
Okay. Well, let's quickly look at it again. Yesterday we classify. Oh, sorry. Breast cancer based on genomic profiling.
Lumina A is ER positive, low KI67,
Yeah.
and R2 negative. Luminal B is still ER negative, but Ki67 is I, and R2 may be positive or negative.
Yes, I think there should be a table. Oh, we had a very beautiful table yesterday that disappeared now. A had two enriched is AR negative, yes, AR PR negative, Ibiza like is triple negative. Okay, Ki67 more. Okay. Okay, let's continue.
Everyone is happy.
Claudine low breast cancer typically exhibits what?
Which one?
What are Claudine low cancers?
I'm not very sure. It says they said it resembles stem cell and shows
I don't even know what Claudine low breast cancers are. What
I'm
are
not sure
Claudine breast
too.
cancers? Explain. Let's look at what you have to say here. What are Claudine low breast cancers? Claudine low breast cancers are a specific molecular subtype of breast cancer identified through gene expression profiling. So when you do gene expression profiling to know what genes are turned on, what genes are turned off. There are some genes, there's some that Claudine is not produced. You know, they call these ones Claudine low breast cancer. They were recognized after researchers noticed that some tumors didn't fit neatly into the previously described subtypes like luminal A, luminal B, HER2 enriched or basal-like. These cancers are characterized primarily by low expression of tight junctions proteins. You know, Claudine is actually tight junction proteins. And these proteins, you know what are tight junctions in histology?
Now in between cells now.
Cell membranes, yeah. So Claudines are found in cell membranes, tight junctions of membrane. That's just tight junction proteins. Like have examples are Claudin 3, Claudin 4, Claudin 7. So Claudin low breast cancers, they have low tight junctions. So what does that predispose? It means the cancer cells should not be able to be cohesive to each other. They'll not be very cohesive. So there'll be lots of cell adhesion features. And that will make them to kind of disseminate, right? Or break apart, like the brick wall, the wall formation will be difficult. So, and these Claudine low breast cancers, they have stem cell-like traits. What is a stem cell-like trait?
Sorry.
What are stem cell-like traits? What does it mean?
Maybe stem cell like is that maybe they are poorly differentiated.
They have capacity to differentiate into anything, right?
Mm.
That's what I think. So first of all, Claudins are stem cell tight junction proteins. So Claudin low breast cancers will have low Claudins or tight junction proteins. They will loss of cell adhesion. And then these cancers will have stem cell-like traits. And the features of epithelial mesenchymal transition is another thing they have. A biological process where epithelial cells lose their adhesion and gain migratory and invasive properties. Does it make sense?
Mm.
Call it EMT, epithelial
Whereby
cells begin to
they lose their
Mm.
adhesion and gain migratory and invasive property.
Yes, why do they lose their adhesions?
No, it's a step towards metastasis now.
Yes, but why did they lose their adhesion in this case? Because their Claudins are low. Remember, you need claudins 3, 4, 5 in your third tight junctions for the cells to be cohesive. You understand?
Yeah.
So when in this claudin low breast cancers, they lose claudins. So the cells become discohesive. And then they start spreading, they start migrating between the mesenchymal tissues. So we call it EMT property. What's EMT, guys? EMT is acronym that stands for what?
Epithelial mesenchymal transition.
Yes. So that's when epithelial cells gain the capacity to what? To migrate and to invade. That one thing that helps in invasion of the breast cancer. As they begin to invade, normally we wonder why should the breast cancer start invading the mesenchymal tissue? Because they have lost their claudins, because they have EMT properties. So the answer is stem. So the question was this. The question was claudin low breast cancers typically exhibit what? Mature luminal features to stem cell-like expression. They try to explain the answer. Stem cell-like expressions, stemness. Claudin low tumors exhibit gene expression profiles resembling normal mammary stem cells. They express low levels of differentiation markers that will indicate mature specialized cell types. So stem cells are actually very poorly differentiated, like you rightly said. They have not yet differentiated into anything. Instead, they express markers associated with pluripotency and stemness, suggesting a less differentiated state, which contributes to the aggressiveness and treatment resistance. EMT features. EMT plays a role in generating cells with stem cell-like properties. Claudin low cancers highly express EMT-associated transcription factors like ZEB1, nail twist, the epithelial migration transition, epithelial mesenchymal transition thing, factors include ZEB1, nail twist. These are things that they express a lot and they help them to become more aggressive and invasive. What expressions show that a breast cancer is mature? What are mature luminal features of the breast tissue? What are mature luminal features of a breast tissue?
Actually,
The mature luminal features of a breast tissue.
I'm not sure what that is.
These are that these are markers that show that this breast tissue is mature. It's not in a pluripotent state. They are ERPR. These are found in well-formed epithelial structures. So when you have ERPR, it means that breast is well differentiated. I mean, it's like a mature marker showing that this is a breast tissue. It has terminally differentiated into a breast tissue. But when it lacks ERPR, it means that it is more in a primitive state of differentiation. It's not yet a mature luminal. So mature luminal features like ERPR positivity that show well-formed epithelial characteristics of the breast. I don't know if it's clear. So claudin breast cancers, since they have stem cell-like properties, do you expect them to be AR positive, PR positive, or not? Hello?
Hello, sorry.
So say claudin low breast cancer, will they be AR positive or AR negative?
I don't know. Are poorly differentiated. They will be negative
Yes, why would they be negative?
because they are stem cell like now.
Yes, only mature luminal features, maturely developed breast cells will be ER or PR positive. So these things will be more or less negative. So would that be there'll also be HER2 negative as well. There'll be androgen receptor negative as well. So they're going to be kind of triple negative tumors. But at this in addition to being triple negative, they're also going to have invasive properties like they're going to have EMT features and all that. So let's come back to the question. It seems you're feeling sleepy.
Okay.
Claudin breast cancer typically exhibits what? It seems you are feeling sleepy.
Sorry, which number is that?
Number 4.
Finding low breast catheterization is mature force. Stem cell is B. Stem cell like expression.
The basal-like tumors are characterized by what?
Expression of cytokeratin 5 and 6 and EGFR. They are also
Yes.
triple negative.
Yeah, they are triple negatives, but this differentiates them from other triple negatives.
Okay.
You remember?
Yeah.
The other triple negatives that are in breast cancer, but basal-like tumors express CK56 and EGFR to differentiate them from other triple negatives. HER2 enriched tumors by gene expression profiling are what percentage of their HER2 is positive to make it HER2 enriched?
20 to 80%.
Yeah. Remember that. Can you still remember how we read HER2 markers? You should remember how we interpret it. What is the benchmark for interpreting it?
Is it not 10%?
10%. So what are the 4 scores you can give HER2?
Less than 10%.
No, 0, negative.
Okay.
Yes, I agree with you. Okay.
Less than 7%, but no stay and no staining. Less than 10%, but with staining. Right?
Greater than 10%, but it's okay. Now let's look at this IHIX interpretation. Continue.
Though that less than 10% is one is with no staining at all, then one is with staining. Then greater than 10%.
Define weak staining.
Is it not subjective? I'm not sure.
Remember that you divide it, there are 4 scores. We have 0 plus 1, 2 plus 0, 1 plus 2 plus and 3 pluses.
Okay.
How about that? The first 2, we look for incomplete membranous staining. Incomplete. The stain does not completely surround the membrane. Okay. But so the first 2, there's incomplete staining. So what's the difference? Then the last 2, there's complete membrane staining. 2 plus and 3 plus has complete membrane staining. 0 and 1 plus has incomplete membrane staining. For 0, which is completely negative, it means that the incomplete staining is still in less than 10% of the cells. Most are completely negative, but less than 10%, like 5% have incomplete staining. But 1 plus means incomplete staining, more than 10% of the cells, but incomplete staining. Now, once it's complete staining, the next you want to look at is it a strong colored staining or weak color? If it's a strong color, that's 3 plus. If it's strong color, if it's weak color, weak or moderate color, that's 2 plus. Provided there's complete staining. So everything is greater than 10% except the negative. Okay.
Okay, let me look at it again.
Well, you look at it quickly. We'll look at it again.
Negative, no staining, so it's 0%. It's a very complete staining. Okay.
Let's look at picture examples. If A, what is A? What is your score for A?
No staining.
What is your score?
No staining at all.
There's no skill. Okay, just give it a score first.
Is 0.
0. Why do you call it 0?
So there's no membranous staining.
At all. Good. Or if at all there's membranous staining, it's very weak and it's less than 10%. Okay. What
Yeah,
about
that's
B? What will you call B?
there's weak staining
Uh-huh.
in more than 10% of the tumor.
So what score would that be?
Incomplete membranous staining. But I can't even see it though. That'd be 1.
1 plus. You have to get just 1 plus. What of
1
this?
plus. B is C, right?
Yeah.
As weak complete staining
Yeah.
in more than 10%
What is
of the
that?
tumor with more than 10% of the tumor cells.
That's what.
2 plus.
2 plus. What of this?
Complete staining in more than
Strong.
10. Strong staining. Strong complete staining.
More than 10. So what is this?
That would be 3 plus.
So which of them would you give trastuzumab therapy?
The 3 plus.
What will you do in the case of 2 plus?
2 plus, we do fish.
You fish, very good. So there's this HER2 enriched tumors gene expression. What's the criteria for calling something HER2 enriched?
Where is the question?
This number 6.
Is it something the tumor positive by I?
Yeah. If the
It's more than
percentage of cells
10%.
positive is 70 to 80%.
Mm,
Yeah, if that's what is positive, 70 to 80%. Remember, you just need more than 10% to call it
yeah,
3
yeah.
pluses. But if it's so positive, like the one we see here, assuming this one here is ER negative, PR negative, but HER2 70 to 80% like this, then that's HER2 enriched. Okay. Which of the following breast cancer subtypes typically shows the highest pathologic complete response to chemotherapy?
Again, baseline.
Basal-like, that's shocking. How do you differentiate basal-like
High
breast
pathologic complete
cancers?
response. That would be A. I actually feel think A. But basically, like usually you use chemotherapy for them straight.
Yeah, what's highest pathologic response to chemotherapy?
But actually, Lumina A, you may not need chemotherapy.
Yours is hormonal therapy.
And yes,
Yeah.
you may not need chemotherapy. So if they're talking about chemotherapy, maybe. But highest complete response.
Mm. Yeah, that's it. Basal-like cancers are negative. GF, maybe. Okay. Let's continue. So, number 8.
Number 8, molecular apocrine typically AR negative, sensor positive.
What are apocrine breast cancers? You know them? There's apocrine. No, you know how apocrine looks under the microscope.
Like eosinophilic,
Yeah,
abundant eosinophilic,
yeah.
luminal secretion,
Yeah. No, the cytoplasm is what that's about is definitely.
cytoplasm. Yeah,
And the
well,
time they may have some tufting or let's say corrugated appearance. or let's put it diluting appearance. So they say that's any very hobnailing or something. So let's look at this quickly. We'll soon go on my 1 hour break. Will you be able to come back? I believe you should.
I try. Another thing is stupid and try.
Actually, you are making, even though it's slow and steady, but at least some of these things are reinforced. I keep reinforcing concepts. You'll be surprised when it will come in handy. You'll be so surprised, I'm telling you. Molecular hypochronic breast cancer. What are molecular hypochronic breast cancer? Molecular hypochronic breast cancer is a subtype of breast cancer that look like hormone-driven tumors, but behave differently at the molecular level. They are called hypochronic because they show hypochronic differentiation. This means that they have certain features like abundant eosinophilic cytoplasm and prominent nucleoli resembling hypochronic spheric glands. Hormone receptor status. Most breast cancers are classified based on whether they express estrogen receptor, progesterone receptor, or HER2. However, molecular hypochronic tumors are unique because they do not express estrogen receptors. They actually express androgen receptors. In other words, they are ER negative, AR positive. Molecular hypochronic breast cancers are ER negative because they lack estrogen receptor expression. They're androgen receptor positive because they highly express androgen receptors, which drive their growth. Their pattern, ER negative, ER positive, helps to distinguish molecular hypochronic cancer from typically benign breast cancers, which are ER positive, AR positive. Typical breast cancer are actually both ER positive and AR positive, whereas hypochronic breast cancers are ER negative, AR positive. Masculine molecular. I don't need to what that is. So molecular hypochronic breast cancers are going to be ER negative, AR positive. Typical breast cancers are. So what option is option A?
Yeah, positive. Yeah, positive. Which one is this one?
Typical breast cancers are going to be ER positive and AR positive. But a molecular hypochronic breast cancers are going to be ER negative, AR positive.
Okay.
Question number 9. Which gene expression subtype shows the poorest prognosis without therapy, but benefits greatly from chemotherapy with up to 40% complete pathologic response?
Basal light, one.
Yeah, despite poor natural prognosis. Normal breast cancer subtype likely results from what?
Tumor with abundant tumor and normal tissue contamination.
Yeah, somebody wants to take a section of breast cancer. He went and cut a little part of the breast cancer and a lot of the normal tissue. So that would be like normal like breast cancer because of it's an artifact due to they take the sample. They took the sample. So it's a lot of normal stroma, normal tissue, but little sprinkled cancer. So normal like breast cancer. Maybe on biopsy or something, I don't know. Or this was section. Lumina B tumors differ from lumina E tumors by what?
Hair proliferation.
Yes. Which marker is consistently positive in molecular hypochronic cancer?
Androgen receptor.
Yes. Claudine low cancers compared to basal cancers typically have what?
Better prognosis.
That's even surprising. I thought they will have worse prognosis. Which feature is shared by both basal-like and Claudine low breast cancers?
Basal light.
They have triple negative.
Triple negative.
Why do Claudine low breast cancers actually have? Why do they have triple negative in the first place?
Why do they? Okay.
Because they exhibit stem cell-like properties. They behave like stem cells. They have not matured to terminally differentiate to be able to express ER, PR, and HER2. So they're going to be triple negative.
Stem cell like it. Okay.
Yes. But why? How does basal like? Why? How do basal like cancer different from other triple negatives? Basal like cancer. How do they differ from other triple negative cancers? How do you think?
I want to question
How
which
do
number?
number 14? How do basal like cancers differ from other triple
CK56
negatives?
EGFR
Yeah,
expression.
CK5 and EGFR positive. Pathology complete response rates for HER2 positive tumors after chemotherapy and targeted chemotherapy is approximately what?
For into 25 to 40.
25 to 40%. So HER2 positive tumors show good, but not as high as basal. HER2 positive breast, so HER2 positive cancers, they show good response to trastuzumab, but only 25 to 30% response. Not as good as basal cell response. Basal-like cancers, what percentage of basal-like cancers respond completely to treatment, chemotherapy? What percentage?
Not sure.
Basal-like cancers that have complete response to pathological chemotherapy, how much percentage? We mentioned it earlier. It was 40%. Well, basal-like cancers show a PCR. PCR stands for pathology complete response of about 40%. Okay.
Okay.
Yes, thank you very much. So will you be able to come back? Should I call
I'll
you?
try. Yes.
Okay, I'll call you in the next 1 hour or so.
Okay.
Thank you for coming.
You're welcome.